From the JAMA Network, this is JAMA Psychiatry Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Psychiatry.
Hello and welcome to our listeners from around the world. You're listening to JAMA Psychiatry Author Interview Podcast. I'm your host and web editor, Dr. John Torous. Today we're thrilled to be discussing a new paper just out in JAMA Psychiatry, Effective Components of Collaborative Care for Depression in Primary Care, an Individual Participant Data Meta-Analysis. We're about to be joined by one of the authors from the paper, Dr. Jurgen Unutzer, MD, in the Department of Psychiatry and Behavioral Sciences at the University of Washington in Seattle, USA. As the prevalence and burden of depression continues to remain a challenge across the world, innovative models of care, like collaborative care, offer an essential tool to increase both access and quality of services that we can offer patients. While many of us may have heard of the collaborative care model before, how do all the parts work together and which ones may be the most impactful? To learn more, we'll explore the results of this brand new study just out in JAMA Psychiatry. So thank you so much, Dr. Unutzer, for joining us. And let's start at the beginning. What is collaborative care?
Well, hello, John. It's great to be with you and to talk about this work and to speak on behalf of a team of researchers led by Hannah Schillock and the team in Germany and colleagues around the world. So you asked about collaborative care. Collaborative care is a team approach. It's a team approach to caring for people who have depression in primary care. Well, why in primary care, you might say? Well, it turns out that the vast majority of individuals struggling with even pretty severe depression, they don't get care from a mental health specialist, such as a psychiatrist or a psychologist, but they do present to their primary care doctors with symptoms of depression. And that's a great opportunity to identify and help millions of people around the world who are struggling with depression each year. So collaborative care is a team approach to addressing that problem. The patient is identified and treated in primary care by their usual primary care provider with support from a trained mental health professional. Sometimes we call that professional a depression care manager, and that could be a nurse, a social worker, or another professional who has some additional training in mental health. And each of these primary care-based teams has support from a psychiatric consultant. So that's the basics of the collaborative care model.
We're lucky to be speaking to you as one of the people who really, I'm going to dare say, invented or kind of promoted and helped move this model forward. So it's exciting to see your initial work has blossomed into something that's used around the world. And now we get to pick it apart and see the different pieces working. What was the evidence for collaborative care before this impressive study?
Collaborative care really is one of the most well-established and effective approaches to caring for individuals with common mental health problems such as depression or anxiety. We initially established the effectiveness of this approach in a couple of very large studies in the US some 20 years ago. And since then, there have actually been more than 100 additional studies here in the US, but now also in a dozen other countries that have really shown that this is a very effective way to care for people with depression and anxiety. So I would say the overall evidence base for this collaborative care approach is really quite strong.
I mean, I know my hospital in Boston runs it, which is also just telling it it's everywhere. And though in the paper you notice you almost wish implementation would be even more, it could expand. What do you think has stop some teams or hospitals or systems from taking this really effective, really well-established evidence-based intervention and doing more?
I wouldn't say that it's rarely implemented across the board, but there are healthcare systems, just like you just said, here in the US that have seen pretty widespread implementation of collaborative care just in recent years. But it is true that across the world, the vast majority of people presenting to a primary care doctor with depression really don't have access to this kind of effective evidence-based model of care. And so when you think about reasons for that, there are a number of them. One of them is simply money. When we have a new invention, a better way to take care of somebody, sometimes the way we pay for care doesn't follow with that right away. So it takes some time until insurance companies and government payers figure out how to pay for a new model of care. That has been a challenge, and I think that's starting to really get solved. The challenge that I think we're taking a look at in this particular paper is a different one, and that is Collaborative care isn't simple. It's a complex model of care. It requires several team members collaborating, communicating effectively as a team in primary care, and it requires some changes in practice that are harder to implement than just telling one provider, use a different kind of treatment when you see one patient in front of you. So that's really the barrier I think we took a look at in this paper, the fact that it's a complex model, that it has multiple components, and it can be hard for people who are looking to implement that approach to sort of say, what are the things that really, really matter? And that is exactly what we tried to take a look at in this paper.
To dive into the paper, you note that we used random effects models with individual participant data for improved precision to investigate the components driving the effectiveness of collaborative care for depression in adults in primary care setting for 4 to 6 months post-randomization. What do you mean by a random effects model with individual participant data for improved precision? And how is this review different than, say, prior reviews one could find on collaborative care?
So I would say in brief, what is used in this paper here is a pretty sophisticated statistical approach that allows us not only to look at the aggregate findings from each of the 35 studies that we included here, but to model more precisely and with more statistical power potential contributors to the effect of collaborative care using the data from each individual, each one of the more than 20,000 individuals who participated in these studies.
Which is a very nice approach to get individual data from so many studies. That N is a huge sample.
It's a lot of work that the team in Germany did to try to pull together individual data from all of these, more than 30 studies.
And let's talk about those individual studies and data sources that you used for the review. What was the eligibility for these studies to make it into the review and have the data pulled?
So for this individual component meta-analysis, we really cast a pretty wide net, tried to identify all randomized controlled trials published from the late 1990s until March of last year, 2024. Every study that compared collaborative care for depression in primary care to usual primary care for individuals with depression who were 18 years or older. That's what we tried to include here.
So you really were inclusive. Almost anything would be eligible. And then when you look at so many different papers and studies over time, depression is measured differently. Some teams will use the PHQ-9, some teams will use different measures. How do you have a common output of depression across time, space, researchers, clinics?
That's another challenge that you have to kind of address when you combine data from so many different studies. So you're right, there are a number of ways to measure the severity of a person's depression. And all of the studies that we identified for this used a previously validated tool such as the PHQ-9 or a similar kind of tool to measure depression severity. But these tools do vary some. So we tried to standardize the individual depression outcomes across all these different studies and the different measurement instruments used by using a previously established cutoff score for each of these measures that says this is the score that you have to have for a person to have clinically significant depression. And so when we standardized across all the measures in that way, we were able to really compare across the different studies and the different measures.
I'm getting a sense you and the team in Germany were very busy with finding all these studies, coding them, standardizing the measures. There's one more very impressive thing that you did. You and the team coded 5 aspects of collaborative care that assess the intervention components and their intensity. What are these 5 aspects for listeners? Can we talk about the results for each of them? What are the 5 parts you're looking for that make great collaborative care?
You're right. I think this is one of the more innovative approaches of this study. So to try to tease apart the different components of this multi-component approach, what we tried to do is identify 4 core components of the collaborative care model. The first one is this notion of a multi-professional approach to patient care. So there is a primary care doctor and at least one other healthcare professional that work together on a team. The second one is the notion of a structured plan to manage the depression, meaning that we are using evidence-based guidelines, protocols, and treatments such as medications or psychotherapy. The third component is the idea of a proactive scheduled follow-up to make sure that when a patient is started on treatment, they don't fall through the cracks, they don't get lost. And the fourth component was enhanced interprofessional communication, making sure that this team in primary care really communicates effectively. That's what we set out with when we sort of planned this. But then as we got into the study, we came to appreciate that actually when you start modeling these components using statistics, many of these components overlap in the way they affect outcomes. And so we arranged these 4 items a little bit in the analysis, and we examined a bit further 4 groups. And those 4 groups are, the first one is the notion of making care patient-centered. So making sure that the care offered really respects the patient's individual preferences, needs, and values. The second component evolved to be the notion of a clear therapeutic treatment strategy. So making sure that effective treatment strategies are used as part of the care that's offered. So effective psychotherapies, effective medications. The third component that we ended up specifying was this idea of measurement-based care. So making sure that we carefully track depression outcomes for each patient every time they come in and making treatment adjustments as needed if patients weren't responding. And then the fourth one was this concept of integrated care, making sure there really is strong teamwork with a close linkage and collaboration between the primary care providers and their mental health partners on the team. So those 4 things that we set out initially evolved a little bit, but that's what we ended up really analyzing in the study.
These are our components. How do they matter? Which ones matter more? Which ones matter less? We'll start just by saying, of course, it's a package. They go together. No one here is saying that you can take away one part and just have measurement-based care. I think you guys did some really exciting analysis, and we've never seen results like this. So now that we understand the setup, let's hear what you learned.
The first thing we found is we actually confirmed something. We really confirmed that most patients in these studies do get better, especially the patients who are getting collaborative care. Now, all of these studies had control groups, and the control groups involved usual care for depression, which means a primary care provider offers the treatments they would normally offer without the collaborative care model. And what we found is across the board in every one of these studies, the collaborative care approach beats that usual care approach. So that's important to have confirmed. But then what we did, we really tried to tease apart what are some of these core components of this intervention. And what we found is, as you said, that all of these components have some benefits, but there were really 2 components that had the strongest association with improved depression outcome. The first one is this concept of a therapeutic treatment strategy. So in other words, making sure that when a team offers care, it's offering evidence-based treatments such as brief effective psychotherapies in the primary care setting. And that really emerged as crucial, perhaps the single most important factor. The other component that came out pretty strongly was the idea of involving significant others, such as a family member or a friend, in the care of a patient with depression. And the idea there is that when we involve significant others, such as a family member or a friend, as part of the treatment team, that can help with keeping the patient engaged in care. It can help with supporting them as they're trying to make changes in the way they behave, in the way they think, and that really can help contribute to helping improve their depression. So I think these are the 2 factors. The first one, again, the concept of having active evidence-based treatments as part of what we offer. And the second one, this idea of involving a family member or a friend in care. Those are the 2 components that had the strongest association with successful depression outcomes in this set of 35 studies.
When we think of the clinical implications of these 2 components, especially, in the paper you break it down that one of the key parts is like having, and sometimes different well-known therapies or manual-based psychotherapies like CBT, and of course in family and friends. But clinically, does this mean I should run out and bring family members into the session? Probably not. That would violate HIPAA. But how would I perhaps begin to think of clinically operationalize these or checking up on my collaborative care model, knowing these 2 are so important?
We're both clinicians, and I think what this study found, it really confirms what many of us who've been working in this field for some time have been suspecting, that active evidence-based treatments, such as effective psychotherapies, really are a key and a crucial ingredient to any kind of care approach that really will make a big difference. And for people who are starting to implement these models, it's a reminder that we need to do more than just putting a team in primary care. We need to more than just adding a mental health professional to primary care. We need to make sure that that team actually provides evidence-based treatments, such as good psychotherapy. The other finding that we had, this idea of the benefit of involving a significant other, such as a family member or a friend, I think that's a bit more of a recent finding, but it makes sense that if you're working with a depressed patient all by yourself, the treatment may not be as effective as if we find a way to help somebody who is a part of the patient's life and engage them in the treatment and in supporting the treatment when the patient is not in clinic with you.
Having those family meetings is so important for helping people leave the inpatient psychiatry and have a good plan. And I think sometimes in outpatient, we may forget that the family and the support structure is really important in offering these treatments. So it's a very good reminder to think that those best practices extend across the care continuum for our patients. And we want more people to adopt the collaborative care model because it works, it saves money. You've shown that. For people listening to this, new clinical directors, medical directors saying, I want to start a collaborative care program, what advice do you have from your years of doing this in this research study? How do you build these programs on the right foot?
Oftentimes people start by saying, okay, we need to pay attention to mental health in primary care. Let's add a mental health professional to the team. They hire somebody who works in the primary care setting, but they haven't really thought a lot about how, when you add another person, how to actually create a team that actually delivers these evidence-based treatments in a team approach. That's sort of like making music. You can have two beautiful instruments, and if they don't play well together, it's pretty awful music. In some ways, you're better off just listening to one instrument. Collaborative care is sort of like having a little chamber orchestra. A couple people have to make beautiful music together, and when it comes together, when it's a really well-integrated team approach where everybody knows what their part of the job is, it can be really, really beautiful music.
I like that metaphor a lot because, again, everyone is trying hard in that metaphor too, right? But if you're not in sync, it doesn't come out despite really good work by all the team members. It's a beautiful way, actually, to describe it. In terms of perhaps what you've seen about, again, engaging family and friends, how successful teams done that you would recommend, realizing it's going to vary by the site and the clinical need?
It turns out that sort of an obvious thing, you would think, okay, that makes a lot of sense. If I can get a family member, somebody who's close to the patient, engaged in treatment, let's do that. But it turns out that's actually not so simple. When you have the patient there, maybe the patient even comes to the visit with a family member, but you already mentioned we might have concerns about that. So I think ideally what we do is we first make sure that the patient is really comfortable with this approach, that we address any concerns that they might have about privacy. Sometimes they share things with us as healthcare professionals that they haven't even shared with some people who are very, very close to them. So we got to make sure that we are addressing that with the patient. We're making the case to the patient about how or why it might help to have a family member involved. And then I think we need to think about what does that family member need to be a good part of the treatment team, to be more than just a person who brings you to the visit, but to really be a part of the treatment team. And so what they might need is some basic education about depression, about how we treat depression. They might need some skills training to become a member of the team, to make sure the patient stays hopeful, to make sure the patient stays engaged in treatment, to help the patient make the kinds of changes that we have to make when we're depressed. So oftentimes we're talking about things like behavioral activation and good psychotherapy, and those are the kind of things that we might have to teach to the family member who becomes a part of the treatment team.
Any high-level takeaways? Do these results match what you've seen, Dr. Unutzer, before, or differ, or roughly the same?
First of all, this big study looking across 35 studies, it really confirms the robust and strong benefit of using collaborative care when we try to treat depression in primary care. Across the board, that really is an approach that beats usual primary care across all of these studies done in different settings in different countries. What this new study adds, I think it adds some important granularity, and it gives us some clarity about what is really important when we're trying to implement these programs in different healthcare settings.
And what comes next in this line of research? You've done so much work here. What are your priorities for next steps?
With such strong evidence for the effectiveness of this model of care, we don't have to do more studies to say, does this work? I think now what we need to do is to say, how can we use what we've learned from studying collaborative care to treat other mental health problems in primary care and maybe in other settings? And the next step is to really think about what is the best way to implement effective collaborative care models for diverse populations in different healthcare settings. So not so much making the case that the concept works, but really getting into the weeds about what it takes, who are the best kinds of people to provide the care, how do you make that beautiful music that we can make when we work well together as a team. That looks a little bit different on the ground in different healthcare settings, serving different populations. I think that's what we're working on now.
Certainly important work with such amazing potential. So That's all the time we have. I want to say thank you. Again, I'm John Torous, and I've been speaking with Dr. Unutzer about effective components of collaborative care for depression in primary care and individual participant meta-analysis. To learn more about this research, you can find a link to the article in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Shelley Steffens at JAMA Network. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.